Hello everyone. I'm excited to open the fifth session on this important day. Thank you for the opportunity to speak about such an important topic. I don't know if I'm meeting you before, after, or during lunch, but please join me for the next 10 minutes, and we will address the topic. Actually, it's a topic that is either accepted or sometimes faces double opposition, because we also have the sensitivity to discuss matters surrounding sexuality. And we also have the shame associated with talking about pain and things that came up today. And we are accustomed to thinking that perhaps in Judaism it's not modest or not right to talk about sexuality, about pain during sexual relations. That too is not something that's widely accepted to discuss. I hope that in the coming minutes we can shed light on these two topics. And before I begin to talk about complex discussions that don't have straightforward halakhic solutions, or various examples of cases, I really want to start from the basics. That is, we are really like what we are coming to discuss. That is to say, why? Why is there at all some sort of ora'e dirabanan that there is some issue between relationships? Between a halakhic aspect and pain? If we want to understand it, I took notes. I chose two fundamental principles. There are many more, but an example is love your neighbor as yourself. The sages, they define it as more than that. They illustrate what you hate, don't do to your friend. That is to say, if something is unpleasant to us, we won't do it to another person. Not only that, but it's not just general statements. These are truly principles that guide your individual life, and the life of the community. And of course also in a romantic relationship. Certainly, and especially within an intimate relationship that includes sexual relations, marital relations. Now, we take these principles of loving your neighbor as yourself. We want to do things in a pleasant way so as not to hurt anyone. Simply that. How can an act of closeness and love be? Is that what will cause pain? I mean, how can something that in Judaism is considered sacred, holy, bring about such a thing? This part is very central, a central element within this place. Something that can become a thing of pain. Some sort of source of fear, of pain, of anxiety. How can one address it? And respond to it a little. I want to really understand why there might be some conflict regarding this. Because what does Jewish law say about sexual relations? We do know the importance of marital relations. They are important within Jewish law. That is to say, we have Shiera, Ksuda, and Onae who are not diminished. We have the commandment of Ona, which is a commandment that requires the husband to have sexual relations with his wife. We also know that there is a matter even within relationships. Sexual relations must be within the consent and desire of both partners. And we have the more general principle of ways of pleasantness, where we express that Jewish law wants it to be, in essence. Generally, we want to invigorate our lives in a way that is balanced and balancing, nourishing and not oppressive. I'll explain how these things fit together. Okay, now I'm bringing in another halakhic principle that is, pains us, a commandment through a transgression. What does a commandment through a transgression mean? Our sages teach us that when a commandment is performed through a transgression, it is not considered fulfillment of the commandment. Now let's try to understand this for a moment. It's a small point because there isn't any thought involved here. This is that when there is pain in sexual intercourse, we are not talking here about someone who in 99% of the cases, it's not accidental that someone is intentionally causing harm here. There is some pain that exists. He is present inside sexual relations, and how we relate to it in a way that is, that it's a part of sexual relations when it is, if it is, something that causes pain. When we spoke earlier, we said it should be something that is pleasant and good. So, there's some kind of inherent conflict with that. Some kind of transgression. So how can there be a commandment here? We need to stop here and think about it. As I said at the beginning, why actually? Surely we understand if you've heard all the wonderful lectures that have been and will be, even when there's pain, it's not something we want to take for granted. It's something we need to pause for a moment and examine it. Why is there even a question here? Why does it even arise? Why do I even need to present a slide on the halakhic aspect? Where does the thought come from that there might be some kind of problem? And here I am to say that there is an issue on the scales. Many times, a lot of confusion comes from couples with a great deal of confusion. Wait, but we have a commandment, a very important commandment, be fruitful and multiply. It's a very important commandment, wasting seed. Oh my gosh, what are we doing? There are so many fears and so many things that we've done. So if sexual therapy might require some pain, many couples are scared of that. They say, wait, maybe actually there's something we need to bite down on. And they're doing some sort of ritualistic maneuvers. And they say, oh, this is probably more important if we deal with the pain. Certainly it comes from a place many times. They find women who come with some kind of appeasement attitudes. Or even perceptions they grew up with that they need to be there for their husband. And how important is that, and what is their role? So we can often find people who remain with this question within themselves. And I'll soon explain what we're doing and also there. It will be that we won't go into the details here, simply because it's really very individual. But first, it's about understanding the distress of a couple who arrives and thinks for a moment, could I be here at a dead end? Am I in a place where there's nothing I can do? It's a little painful, isn't it? That's right. But there's the halacha. And the halacha is here. This message is important. It doesn't intend for sexual acts to include pain. What are we to do? Okay, so we said. The first 3 steps are quite similar. You'll find them everywhere. In any treatment of a problem with sexual pain, okay? We work according to the biopsychosocial model. We pause for a moment if there's pain. We listen to it. Okay, so what's the reason for this pain? We want to listen. We're checking to understand why there's pain. We're seeking treatment, okay? There are different types of treatments that we'll start with. As Ahino mentioned, we'll diagnose and check what's going on here. What's at issue and what do we want to address? And that's where the unique aspect of the halakhic perspective comes in. Because a person arrives with a set of values, religious and halakhic, and even here there's a very wide range of. How far does it go? What line? Rabbis follow according to what they practice in order. But there's still some kind of value system that guides them and motivates them. Very important that they feel and know that there are solutions. That is to say, in 2 senses. I say this because also, even when they seek treatment, it's important that the therapist understands that there needs to be some kind of collaborative work. This work should involve sharing with them. A therapist who understands they are in some kind of conflict. I've seen many rabbis these days, thank God, who deal with matters of Jewish law. They work very hard. They study and examine how to find Jewish legal solutions within the boundaries of Jewish law, for complex situations, within relationships, within the world of sexual relations in general. And there is also organizations that are rabbinic counseling and also medical halakha, even in daily life. And it's important to know that there is a solution. It's important to know that although there are sometimes challenging halakhic dilemmas, yes, that is to say, we are going to go to something that appears terribly simple, like a woman who is in pain in her groin area and has some dryness. She uses applicators without lubricant. So she has pain, and if they want to have sexual relations on Shabbat. And from her perspective, it is forbidden to put anything there. Like to apply oil on Shabbat. So what then? So, do they have no choice, or are they not having relations on Shabbat? Or will it hurt her? Okay, so we're coming to tell them no. Yes. Sorry. We have a minute to finish. Easy to finish. Okay, so I'll put this in. Together. So really. Absolutely. Thank you for sticking to my time. I even set a timer, but I didn't look at it. It's not that effective. And then whatever I say. The main point I want to get across is that because of the weight and importance of sexuality in Judaism, and because of the laws associated with it, and really couples come with, well, that is to say, it comes from a very values-driven and important place. It should be understood that our body is not an obstacle to serving God. They are the tools through which we work. That is to say, they deserve to be treated well. And when there's pain, it's not a point of failure or an obstacle. It's a time to pause, to consult with someone who can help. Today there really are a lot of options. When there's cooperation, Whether it's a couple who wants to go for individual therapy or rabbinical guidance, or whether it's through the mediation of a therapist. But it's important that it's a shared experience, so they feel confident in the therapeutic process together, with the rabbinical perspective. And there are solutions that are tailored, sensitive, and creative. Don't stay alone, don't stay with the pain, and don't stay with the feeling of being stuck. That you need to choose between one set of values or another. Because there is something that can be done. Thank you for listening. I would say all is well and I wish you all the best. And if I apologize for going over the time, Aviva Fader certainly gave an enlightening lecture. It was very important, so thank you very much. Today I am wearing two hats. First, I will introduce the participants and the panelists and their topic. The second hat I'm wearing is that I am Dr. Angie Ershade. I am the responsible woman, day hospitalization for cervical cancer and lower genital issues at the Perea Hospital, and a private clinic in Naf Hagalil. Today I am giving a lecture to speak about a topic very, very close to my heart. About the pain experienced by Arab women in Arab society. Next, I would like to share the presentation. Okay. Sexual pain in Arab women. A lack of knowledge. There is no clinical reality data specific to Arab women in Israel. When we talk about Arab women in Israel, it's important to say frankly that we don't have enough quality, targeted data on this population. Most of the existing literature is based on Arab or Muslim countries in the region. Therefore, we often have to extrapolate from other research. And do so with great caution. What does emerge from the literature is that pain during sexual intercourse is not only influenced by biological factors, but also by cultural and religious, couple-related factors, and sometimes also from the sexual functioning of the partner. It is also important to note that there are currently no significant epidemiological studies. These studies compare Arab and Jewish women in Israel. At present, my attempt to prepare this lecture is essentially a prominent factor is the gap between the high level of education in Arab society overall and basic knowledge of sexual health. This gap can include a lack of awareness. For example, anatomy, the menstrual cycle, fertility, and sometimes even more detailed information about the body itself. This is not addressed in many studies. Often, there is no formal sex education in Arab schools in the country. On the other hand, teenagers are exposed to information from uncontrolled sources. These include social media, pornography, or unreliable information. This ultimately exposes us to the formation of identity that is not complete. And together they are cultural shame and modesty. And this gap can affect body perception, the formation of sexual identity and expectations around sexual relations, and pain. This is a very, very important topic, the topic of the hymen. It is still very significant for some people, especially in traditional environments. Sometimes there is avoidance of physical contact or the use of tampons. In those situations, therefore, pain during intercourse can become something expected or normal. And sometimes there is a perception that pain is an inseparable part of female sexuality. While pleasure is perceived as more legitimate for men, and a woman's sexuality will manifest as pain, and for men through pleasure, it's important to emphasize, the goal here is not to create stereotypes, quite the opposite. Rather, it's to understand how social and cultural factors might influence the experience of pain, and seeking treatment and making treatment accessible, and something that can't be ignored. All the research points to disparities in health indicators across a wide range of areas. These disparities exist between Arab and Jewish women in Israel. Seems this could have an impact, a significant impact even on the topic of sexuality. So, what are the clinical characteristics and barriers to diagnosis that we're coming to discuss regarding the Arab community? Generally speaking, only a portion of women experiencing pain during sexual intercourse seek treatment across gender lines. As we heard in the previous panel and also, across cultures within the Arab community, unique barriers may also be present. These include fear of stigma and concern about a breach of medical confidentiality. Sometimes there's a feeling that the healthcare system is too close. When the family doctor, the receptionist, or clinic staff are essentially family, the family also has a very significant role. And it has many advantages. However, around issues of sexuality and pain, there can be pressure, misunderstanding, or interference in decision-making. In reference to traditional places, it's important to remember that we are not talking about a uniform population. There is a great deal of diversity among women. It depends on their family background, religious beliefs, place of residence, and socio-economic status. Arab society is incredibly diverse. From the north to the south, this topic is very, very close to my heart. Because even among people in the same village, from the same family, I see the differences and variations every day. Because we are all going to a place where each person is forming their identity in the modern world. And that's also true of Arab society. If I compare Druze populations from the north in the Golan Heights to those in the center and around Haifa, the differences are very significant. In terms of conservatism or the lack thereof, you can't compare and generalize Arab society as a single entity. So, what are the barriers to seeking treatment? If we've already determined that the woman arrived and said she's experiencing pain, what are the barriers? There are language differences. They're very significant when discussing medical terminology. It makes communication even more difficult when we're talking about such a sensitive topic. So, trust and culturally appropriate communication between a caregiver and patient are extremely important. And often the request is for a female caregiver, not a male caregiver. Therefore, language and communication barriers can significantly impact referrals for treatment. They also affect the patient's sense of security. Sometimes it's not just about the language. It can also be about trust, privacy, exposure, and fear of exposure within the community itself. And there are practical barriers, such as geographic distance and transportation difficulties. Simply how to get there technically when there are no buses. Or financial hardship and a lack of Arabic-speaking professionals in the field of sexual health and sexual therapy in general. For some women, the physical exposure and the conversation are simply so intimate. So, the principles, we really don't have many tools that are based on literature. But what is true for every woman is also true for an Arab woman. Therefore, cultural accessibility shouldn't involve making assumptions. It needs to involve reaching out, asking, listening, and tailoring the treatment to the patient sitting in front of us. Avoiding moral or religious assumptions. Let's say, for example, in Islam it can be a bit jarring to me because I don't represent a specific religion or anything. But it's something that came up in the literature. And just seeing it and trying to learn a little more about religions. And every religion says something about it in the sexual context. So in Islam it's about sexuality. It's perceived, it's understood as a right and a duty and a way to express emotion and spirituality. But it's also an area where boundaries and modesty should be maintained. And there's a lot of discussion, for example in Islam, about how to treat a woman during her period. Even though there's a prohibition against sexual relations. But physical contact with the woman is strongly encouraged. And closeness, both physical and emotional, during this time. Part of the treatment actually begins with establishing language and providing information. And bonding with body parts and sensations, a feeling of shame, experiencing a better and better understanding of your body. We don't have any high-quality RCT research examining this. Communication strategies or cultural adaptation in the treatment of sexual pain. So to summarize, what are our knowledge gaps and clinical challenges? There is a lack. And that's already a good start, knowing that there is a deficiency. And that opens the door to future research and work. And whether there are truly unique clinical characteristics and a pattern of clinical stabilization within the Arab community, those are questions that are really open. The main thing, as I mentioned, is imparting knowledge in schools, prominent geographical factors, and socioeconomic disparities. Cultural and linguistic barriers are things we can't ignore. Training and communication between caregivers, between the patient and the caregiver, within gender and social norms. So, what are my main takeaways from this lecture? Pain during sexual relations among Arab women is an area with significant knowledge gaps. Where can we contribute and develop sexual health within the Arab community? A multidisciplinary approach is required. This applies to all unique communities. Thank you. Actually, I need to present the third lecture now. Avishag Rubinstein Stern, a sex therapist and counselor. She is also a psychoanalytic psychotherapist. In addition, she lectures at Sheba and Bar Ilan in the program for sex therapy. She manages the LGBTQ+ clinic for couple sex therapy under very demanding conditions. Avishag, please. It's very nice to meet you, Angie. Wow, it's a great honor to be here today. Just a moment. We're working through a logistical hurdle. Okay, here we go. Alright, you can see me, you can see the presentation perfectly. Great. You know, I listened to your lecture too. And it's amazing how much we really were able to accomplish regarding the topic of cultural perspective. Cut and paste because the topics I'm going to talk about are roughly in the same areas. Okay, let's get started and see. Let's see how we move forward from here. I will say that this is a taste of a taste of a taste. And I hope I don't create more frustration than anything else. Okay, so like that. Angie mentioned it. The LGBTQ community isn't a uniform group. It's a multidimensional spectrum of sexual identities. Basically, ultimately, we're talking about the ability for gender and cultural identity to evolve. These identities are shaped within a social context. They uniquely influence body experience, intimacy, and sexual health. There is essentially no way to compare the state of a person living in Israel in 2026 to an LGBTQ person. For example, an LGBTQ individual lives in Uganda. Okay, now, when we talk about sexual orientation, it's just one aspect of identity. And there's a very, very significant component in the development of sexuality. That's essentially what we gathered for. Today is good. In sexual relations within the LGBTQ community, it's not just a physical phenomenon, of course. It's a complex expression of identity within an environment that includes minorities, trauma, physical identity, and relationship dynamics. All of these meet within the body and within the sexual experience. When I am talking about a person's psychosexual development takes place within a context. We don't live in a vacuum. There's a great deal of value in where I grew up and how my sexual identity is treated. How liberal is the culture I'm in? How necessary is the discussion about sexuality and the versatility of sexuality? It's essential to foster such diverse LGBTQ+ development. Jessica Benjamin is one of the leading sex therapy mothers in the world. She essentially talks about conceptualizing psychosexual development. Just as there's a developmental process in stages like a baby first learning to roll over, and then they learn to crawl, and then they learn to walk. Our sexuality also develops along a continuum. Now, in contrast to stage-based definitions, Jessica Benjamin speaks of a conceptualization that emphasizes sexual development and gender identity. These are built within mutual recognition between the self and the other. I'll give you a very, very small and rather crude example in a moment. But if my son one day wants to go to kindergarten wearing a skirt, I allow this, something specific will happen within his gender development. If I don't allow it and even reject it, something else will develop. That's how networks actually exist within this awareness. It allows for the development of something that is built within me. Okay, when this awareness exists, it allows for differentiation alongside connection. And sexuality can develop as a living, subjective experience. That is to say, personal and mutual. In sex therapy, we will always want this. After all, we usually engage in sexuality again. Even if I am experiencing sexuality with myself, I am always doing so internally. If some fantasy with some earlier statement was present, then it always develops within the context. Especially when we engage in sexuality with other people, which we often do. So, imagine two people meeting from the LGBTQ community. Let's say a gay couple. For each of these men, there's their own psychosexual development. It's enough for one person to develop, and I'll become very, very stereotypical. Sorry. Even if we just consider for a moment a person from Arab society, from the Bedouin periphery. He realizes throughout his sexual development that he is attracted to other men. And he meets a Tel Aviv man. I'm really going with the most stereotypical Tel Aviv man, surrounded by a whole lot of gay men. And he just came out of the closet at a very, very young age. The two of them meet, and they want to have some kind of sexual encounter and form a connection. Just think about the differences. Even though they're both gay. Both men who have sex with men. But the chasm that separates them in their psychosexual development is vast. Okay, which introverted? understandings each one holds, and what happens to sexuality when we are trying to connect such different identities. I want to give here a very important and central place to the body. Merleau-Ponty is considered the theoretical basis for the embodiment thesis. The body is not an object. The body is the way we experience the world. Experiences of the world include sexuality and pain. Arthur Kleinman emphasizes that pain is a subjective experience. It is culturally and socially shaped, not just physiologically. Stacy Sims speaks about the body, gender, and sexuality. Each layer essentially adds another perspective for us. She is very holistic. She deals with the experience of sexual relations. She also deals with the experience of pain within sexual relations. To this body, we, as doctors, as sexual therapists, as people connected to our own bodies, have a mandate. It is very significant to work through the somatic experience of our bodies, and to give pain a space, in and of itself, to give it validity, to understand why it is there. Essentially, we are talking about the body expressing what the mind is not yet able to say. We'll soon see what the body expresses in the context of LGBTQ individuals. So, when we talk about psychosexual development, what is the psychosexual development of heterosexuals, of straight people? There's a slide here that is very oppressive. Now, I could give a lecture for an entire semester on what internalized homophobia is, but generally I'll say homophobia. It's essentially exclusion, discrimination against people based on their sexual orientation. Okay, internalized homophobia. That's all of this that we absorb from the outside. During our psychosexual development, the most common curse word in school is homo. Homo as a bad thing. Okay, a child growing up in an environment where homo is, it is an evil thing. His tendency is actually a source of destruction. The homophobia, the hatred they experience from the outside, becomes part of their inner identity. So, expressions of homophobia are internalized when we come to treat people from the LGBTQ community. It's always a kind of lens. A lens that we need to put on. And we constantly need to think about how this presentation comes into the therapy session. Whether it's somatic disturbances, the pain, or very universal expressions like, I'm not going to hold hands with my partner out on the street. It's an expression of internalized homophobia. Gender role divisions. This is masculine, this is feminine. It's internalized homophobia. We constantly want to ask how this passes through that prism. There's a correlation with depression and anxiety disorders. There's twice as much depression and anxiety within the LGBTQ community. This happens within the population. The suicide rate is 1.5 times higher for LGBTQ individuals. It's twice as high in young people under 20. Attacks or harm cases involving LGBT, according to Near Katz's Center, reports dozens of cases each year. When over 50% of them are women, also as women as a subgroup. They are also more sensitive also towards other people from the community too. We need to place a minority within a minority. Sexual vulnerability in women. The statistics show 1 in 3. The rate of substance abuse disorders is 1.5 to twice as high in the general population. I think the biggest mandate given to us here today is really the majority of the community. A full 30% avoid seeking medical care. I think it's an honor to come and speak about this subculture in front of doctors and healthcare professionals. And we have a lot of power. To get this population to be more receptive to treatment, we need to reduce the pressure. Discrimination needs to reduce so they feel more at home in the room. Whether it's with a doctor, an examination, or in a treatment room. And in this way we can reduce illness and instances of pain. So, internalized homophobia. There's an article by Jiva Schenkman. The article discusses the claim that it's ongoing exposure to that discrimination. He also talks about the suppression of minorities. It creates, for the individual within the community, scenarios of a hostile world, which is essentially a pattern of expectations of rejection and threat. This pattern affects emotional processing and relationships. It leads to constant vigilance, diagnosed difficulties, and a damage to intimacy. If we want to know, for example, what are the generators related to subculture within gay men, transgender women, I'll expand on that shortly. We constantly need to hold on to this feeling that a person experiences, and their lack of belonging within the environment they live in. Because the physical manifestation of the involuntary contraction of the pelvic floor. For the sake of this discussion, this pain disorder, I'm smooth. Essentially, it's a state of mind and emotional state in which the person finds themselves when they are constantly on the defensive, or constantly needing to justify their existence. They are always needing to justify their relationships. There is no structural basis that reflects it, not even in Israel. In 2026, it's always about being in a place where one needs to assert their presence. Let's take a moment to look at the subpopulations, and each one has unique emphases. We are looking at MSM practice. That's essentially the definition for men who have sex with men. I'm saying men gender-wise as opposed to transgender men. Men who feel alignment between their physical experience. They feel like a man and look like a man. The same goes for women. Gender women, like women and feeling like women. Unlike people on the autism spectrum, there is a disconnect between outward appearance and the mental and physical experience. Now, looking at the pains in sexual relations in men have their own unique experience. There's an issue here of internalized toxic masculinity and sexual performance. When I talk about this, I'm saying let's think for a moment about the practice. How one of my patients told me, hearing you're in contact with a man automatically, I ask myself in my head if you're passive or active. That is how much. The presence of his partnership is an intrusive experience. Because it's automatically linked to some stigma that underlies the sexual relationships of gay men. So, I am talking, for example, about how society treats men. How much vulnerability does society allow men? Sexual relations are also considered within the gay community. A position that is passive is less accepted, or less desirable. The active partner is considered more valuable than the passive one. And that too is an expression of misogyny. Internalized homophobia is internalized how sexual practices are taken. And essentially, they are placed within cultural and subcultural aspects. I think in a society as patriarchal and militant as this, Israel today, how difficult it is to be a man who is passive. It's much easier to come out today as a woman who is attracted to women than it is for a man who is attracted to men, especially as society becomes more closed off, less liberal, and more economically focused. So when we encounter a couple of men who are experiencing pain during anal intercourse, we need to ask ourselves what exactly the environment isn't ready for? Why aren't we willing to let it happen? Because often, this holding on to hostile world scenarios in a man-Schenkman type manifests within the sexual relationship somehow. It's a protective shield against homophobia. I'll say something brief regarding women. We don't expect to see problems or pain in women who have sex with women. They have many other practices that aren't related to the male anatomy. But let's not be mistaken. When a couple of women come to the clinic and one of them wants to have intercourse, we shouldn't diminish this practice just because there are alternatives. We need to make room for all the versatility of sexual relations. And if they are interested in intercourse that includes penetration, we need to allow them to work through any pain they experience during sex. Just as we would allow every heterosexual couple, and not detract from the importance of that. The topic is incredibly complex. I'll say a word about it because it is important to discuss it. It's a topic about transgender people, both women and men. And essentially it's a topic about gender dysphoria, where the body is a battleground. I was born gendered, male, and I feel like a woman. I need to undergo some kind of transformation, whether it's emotional or physical, to feel aligned with my body. The journey is accompanied by so many psychological and social traumas, medical traumas. Think about a woman who needs to undergo gender adjustment surgery 53200:33:30, 240:00:33:35, for 30 someone who was assigned male at birth. She needs to transition to become a woman. She needs to go through many surgeries. She needs to undergo a very long process of recovery, pelvic floor therapy, and work with trainers in order to reach a point where she enjoys sexual relations. Now the dysphoria itself also creates a disconnect from her body. To enjoy sexuality, we need to be connected to our bodies. When my body is in the arena, what? We need to conclude. Yes, I finish. So that the body becomes an arena of play, of fun, of pleasure. There are many ways to go through the disruption of pain. So what do we do? Practically in the treatment room? Well, we really have everything we've talked about so far. Biopsychosocial and integrative interventions. That means we need to consider the person within the context of their life. Creating a safe space and validating their identity, whether male or female, man, woman, gay, lesbian. Working with shame and internalized homophobia. Reconnecting with the body. Addressing couple dynamics and individuality. Cultural adaptation and gender sensitivity. And what's important for you to take from this is that pain isn't just a medical issue. It's a deeper cultural context. It's culture and stress. Minorities are part of the diagnosis. The body is also a site of memory, and emotional separation and intimacy influence pain and desire. Effective treatment requires integration between body, mind, and connection. Thank you very much. Thank you very much to you. definitely fascinating. I am very honored to introduce Yahel Mandelkern. Yahel is a licensed clinical social worker and certified sex therapist and instructor. She is an instructor and lecturer in the therapeutic system of the Shack Foundation, Rutam Center at the Hebrew University School of Social Work. Yahel, thank you. Hello, thank you very much. I'm also very excited to see that they renovated here. I asked myself, if I'll find myself if I have a place regarding the topic. And it seems to me that very much so. It seems to me that I also resonate with Avishag. I'll do the things you two said. One moment, screen share. The screen. Sorry, one moment. Okay. Good. So, although the title is Special Needs, disability will be presented here. Then a lecture on physical disability. So I chose to focus on two groups in the population. That seems like a lot to me. For 10 minutes. But I was very sorry to have to give up either of them. Each one really has its own unique qualities. So I hope I can both offer something and meet the time challenge. I'll start with a population with intellectual developmental disabilities, what used to be called mental retardation. I want to mention a few starting points regarding this population to make things clear. And from there, I'll move on to the topic of pain. First of all, it's very important to know that the physical development we're looking at applies to the entire population with intellectual developmental disabilities. The development is usually typical and limited in accordance with the range commonly seen in the general population. This is in the physical aspect, of course. If we're talking about psychosexual development, I want to emphasize the physical aspect at this moment. There are indeed syndromes that it's very important to be familiar with. As part of the medical history when meeting a person with a developmental disability, it's certainly necessary to be aware of the unique characteristics of certain syndromes. Is there an endocrine impairment or is there a difference in anatomical structure? But it's important to emphasize that in large numbers, physiology is generally normal. In all, studies for many years have talked about the fact that emotional needs, social needs and sexual needs of people with intellectual developmental disabilities are completely identical to the general population, and yet, despite this data and these basic attitudes, in reality we are talking about a population that very struggles to fulfill its desires in this area. Despite the identical needs and despite everything being in order, the proper development. The reason for this is their very significant dependence on the environment. In terms of the environment and their place within it, they face the environment. And we are talking about much earlier primary obstacles. That is to say, pain issues are not simple to deal with. But for them, you first need to have sexual relations. So I am talking about obstacles first and foremost to having sexual relations. You can't begin the lecture without talking about it. When we talk about a population with intellectual developmental disabilities, there's a fact here that is very important for you to notice. It reflects a lot. Only in the last 10 years have we actually seen studies where people with intellectual disabilities were interviewed. They were asked questions about the topic of relationships and sexuality. Fortunately, this was available when I prepared the lecture. I had a little more material to draw from. As I mentioned earlier in those studies, this is what most people, I'm relying on this here. Yes, also on studies that are a bit more of a review but on a very important study. One that really asks people who live in out-of-home settings, really about relationships and sexuality, and the barriers they mention are very numerous. First of all, there's no conversation with them. They live in a setting. Yes, it's supposed to provide support and assistance. But there's no ongoing discussion of sexual matters. There's no validation. There's no privacy, which is a very important thing. Sexual relations should happen in a private space. There is no privacy. And when there is a discussion related to sexuality, it often takes place around risk and entering risky situations. It's understandable why, and less so around enjoyment. Studies explicitly show there's no direct reference to the question of whether there is pain during sexual relations. That is to say, it wasn't even examined or directly asked about. People with intellectual disabilities may be subject to stigmas. Despite these thoughts, they do know how to say that sex should be pleasurable for both sides. I'm sharing a quote here, and there are similar quotes in that same study. But again, they aren't asked about it in a more individual way. It relates to their experience there. I suspect, based on my work at the treatment center where I work as well, that it's easy to see that there. And also at the Rodham Center. In both of those places, I meet people with disabilities. It's not that the phenomenon doesn't exist. Of course, we encounter them in clinics. People who report pain, but they report it after they are asked about it. That means they've also been referred. They find it very difficult to say what isn't working for them. Of course, this is part of the unique characteristics that need to be recognized in the population. Regarding how to ask the questions, because of the municipality, I addressed the issue of pain very directly. It's certainly important to understand how we encounter these people, how we ask them questions, how we take a medical history. But it's very important to say that if we don't ask, we won't know. People do. They can describe negative experiences related to sexuality. Yes, I'm providing quotes here again. They talked about something disgusting, something unpleasant, something painful, yes. Compared to other experiences, closeness feels good. I don't bring that up here much. I'm giving more space here right now, even to experiences that aren't pleasant. But despite this description, no specific questions have been asked that really relate to pain and problems with pain. When I talk about the work in the field, we need to take into account that we're dealing with a population with intellectual developmental disabilities. We constantly need to return to the starting point, which is the right to sexual fulfillment. Still question whether we should grant them that right. We know how to assist them in realizing that right. We want to receive more up-to-date information. And the research direction should actually focus on obtaining an accurate picture of pain disturbances in the context of a population with intellectual developmental disabilities. The focus should move away from the prism of the disability. Consider all the background factors that are very significant. For example, there's a woman and a man. How old are they? Are they in a relationship? Are they sexually active? So, what is their experience like? Are they experiencing pain? There's a lot to ask. Can I get some answers? But if the central perspective is related to disability, yes to thought, the groundbreaking kind. Yes, that these people are sexually active. We need to make a shift there, of course. While continuing intensive work related to primary blocks. I spoke about them earlier. They are blocks related, of course, to the environment, their attitudes, and so on. I also want to give you a taste of the autism spectrum population. I do want to say, perhaps in relation to a higher visibility of the population. Fortunately, in recent years in the programs, I think it's a division, and it's something that is truly very significant as well. That is to say, there's more in society. I think there are small steps toward greater tolerance, especially in higher function levels. I'm mainly talking about small steps regarding those higher positions. I'm not trying to paint a utopian picture here. And compared to other populations, I think there's an increase in awareness. And visibility does create change. It definitely provides a better experience of getting to know this population. We're also finding a few more studies that interviewed people with autism on the spectrum compared to people with intellectual developmental disabilities. There as well, the research focus is often in broader contexts. This is very important. I'm not coming to diminish that, quite the opposite. I'm very glad the connection is broad. They were really asked more questions about the topic of sexual awareness, about the topic of gender, the whole issue of gender. Where do I see myself? There are many overlapping questions between gender and autism spectrum. The whole topic of communication between partners and attitudes of the environment. Even though these are high-functioning individuals, attitudes of the environment, of parents and treatment providers are also a dominant theme in research related to the autism spectrum population. Yes, they exist. I'm finishing up, no problem. I want to say here as well, I'm missing some kind of. This is really nice. And it's very important really, but everything's fine, so I'll finish with 2 sentences. I'm saying really that even here in the literature, we don't see any focused or explicit reporting on pain disturbances during penetration. But because the population is very well defined regarding sensitivity, hypersensitivity or hyposensitivity, or overreactivity as it's called, yes. There is more reporting of discomfort, yes, some kind or another related to sexual activity. Now there's still a lot to ask and understand, yes. We see the pain disturbances meeting with the whole issue of sensory sensitivity. Things are already on the table, we're in a slightly more advanced place. There's still work that can be done regarding this. And again I'm saying here, the story of sensory sensitivity is so strong. I suppose I'm allowing myself to assume it will be much faster. That's thanks. Thank you. The opportunity really thank you. Thank you for the lecture. It's truly very interesting. It opens up horizons on things we hardly ever touch upon, as much as we think we're open to the needs of others. I hope today's discussion will help us all to think not only about pain management, but also about the way we allow patients to talk about it. And we have a few questions here. Do you? A question from Aviva. We have a few minutes we'll dedicate to answering it. A question for Aviva. I would appreciate suggestions for practical solutions, even if it requires a halakhic examination for each couple individually. For example, lubrication on Shabbat, or scattering seed in vein to avoid causing pain. These are excellent questions. And we will truly see many nuances within everything. For example, the lubrication. So there's really a whole lot. Rabbis will say that a lubrication that's not very fluid, it's not really spread out, or there's a certain way to apply the lubrication. That means it's also a question within that. Very relative. Simple to solve, but really that is to say there are lubricants that aren't a problem from the start. And if it's a woman's lubricant, she likes knowing it's meant to be applied. So there are also certain ways to apply them that aren't a problem. The subject is ostensibly okay. That's a broad topic, and I'm not avoiding an answer. I just want to say that it's worth examining each couple and what they have. You 3, what's his space like? With whom is he going? Are there solutions that allow for it? Ejaculation doesn't necessarily have to be inside the vagina. There are many options, but there really needs to be someone who understands that we want to avoid pain. And to work together cooperatively because it won't help the couple. I, as a therapist, can't just tell them it's okay. But they feel guilty about the religious implications. Wait, maybe it's not okay, but there is. What kinds of solutions are there, and others like that? Yahel. I have to read this note. It's just a preview though. But it's exciting. It's well placed. Right in the middle. These are the reviews. There's almost another review here. And there's no physical therapy, pelvic area in Arab cities. Because HMOs avoid these areas. And they don't provide accessible and readily available speech and physical therapy. And pelvic physiotherapy patients have to travel 46 minutes by car. Absolutely. We certainly do. I am exposed to it most of my week. I work in central locations. But one of the things I've taken on is working in one of the villages. And it's amazing. The difference is that I receive it from an obstetrician and a hospital unit manager. Or whatever and wherever it is at the health maintenance organization. And the facilities I receive or don't receive. The main thing is that I'm working more in peripheral areas. But that's just the reality we live in. From a sense of belonging and also something else that was raised. The problem is that Arab female doctors still ask the question of whether a patient is married. It's me. It's really important to emphasize that. Don't ask Arab women if they are married or not. I don't really know how non-Arab female doctors phrase it. But don't make assumptions. I personally ask if you are sexually active. The question, and many women are hurt by the question about being married. And I'm very glad to hear people are speaking out about how they don't like being asked if they are married or not. because truly social status isn't a measure of sexual activity. So thank you. Thank you very much to everyone. Avishag, Aviva, and Yahel were all wonderful. It was great to hear your lectures, and we'll meet at 2 o'clock. We're returning to the panel on pain in relationships in society. The panel is related to relationships. The panel will be in Arabic, so we'll meet at 2.